and this is that important step to protect Americans by increasing our stockpiles, and would urge its passage. And with that, Madam Speaker, I would yield back the balance.
Yields back. The question is, will the House suspend the rules and pass the bill H.R. 6672? Those in favor say aye. Those opposed, no. In the opinion of the chair, two-thirds being in the affirmative, rules are suspended. Gentleman from Michigan.
Madam Speaker, with that, I would request the yeas and nays.
Yeas and nays are requested. All those in favor of taking this vote by the yeas and nays will rise and remain standing until counted. Sufficient number having risen, the yeas and nays are ordered. Pursuant to Clause 8 of Rule 20, further proceedings on this motion will be postponed.
The gentleman from Pennsylvania seek recognition.
Mr. Speaker, I move to suspend the rules and pass S. 1440, the PREMI Reauthorization Act, as amended.
The clerk will report the title of the bill.
Senate 1440, an act to reduce preterm labor and delivery and the risk of pregnancy-related deaths and complications due to pregnancy, and to reduce infant mortality caused by prematurity.
Pursuant to the rule, the gentleman from Pennsylvania, Mr. Pitts, and the gentleman from New Jersey, Mr. Pallone, each will control 20 minutes. The chair recognizes the gentleman from Pennsylvania.
I ask unanimous consent that all members may have 5 legislative days which to revise and extend their remarks and insert extraneous materials in the record on S. 1440.
Without objection.
Mr. Speaker, I yield myself such time as I may consume.
The gentleman is recognized.
Mr. Speaker, S. 1440, the Prematurity Research, Expansion, and Education for Mothers Who Deliver Infants Early Reauthorization, or the PREMI Reauthorization Act, would take important steps to protect and improve children's health. The bill includes 3 important programs: the PREMI Reauthorization Act, the National Pediatric Research Network, and the Children's Hospital's Graduate Medical Education Reauthorization. The PREMI Reauthorization Act addresses one of the leading causes of neonatal death and a major cause of childhood disabilities, preterm birth. Since its passage in 2006, the PREMI Act has sponsored important research that has led to improved prevention and care for children born too early. Reauthorization will mean the continuation of the program that will lead to even better outcomes for children. The National Pediatric Research Network is a proven way to support pediatric research by coordinating multi-centered research activities, including those in rural areas. By working in teams, innovative research improves, especially for diseases that are rare or affect a small population of children. Most of the approximately 7,000 rare diseases are pediatric and often genetic, and doctors do not have sufficient therapies to treat them. This bill will help alleviate that problem. The Children's Hospital Graduate Medical Education Reauthorization would enable the Department of Health and Human Services to provide funding to freestanding children's hospitals to support the training of pediatrician and other residents. Prior to the enactment of CHGME, the number of residents in children's hospitals had declined by 13%. Now, the program has enabled children's hospitals to increase their training programs by 35%. In my home state of Pennsylvania, 3 premier children's hospitals, Children's Hospital of Pittsburgh, St. Christopher Hospital for Children, and Children's Hospital of Philadelphia, receive CHGME funds that support and ensure world-renowned health care for children. CHGME is a significant achievement in pediatric health care in Pennsylvania and across the country. Despite these gains, shortages still exist, and the future of the pediatric workforce relies on the continuation of CHGME. I commend the leadership on both sides of the aisle in the committee for their leadership on this. These programs enjoy bipartisan support, and I urge my colleagues to support S. 1440, and I reserve the balance of my time.
Gentleman reserves the balance of his time. Gentleman from New Jersey.
Thank you, Madam Speaker. I yield myself such time as I may consume.
Gentleman is recognized.
Madam Speaker, I am pleased to rise in support of S. 1440 as amended. The legislation before us extends 2 existing programs and creates 1 new initiative, all activities that impact children's health. The first title of the legislation reauthorized the Prematurity Research, Expansion, and Education for Mothers Who Deliver Infants Early, or PREME Act, through fiscal year 2017. The PREME Act was signed into law in 2006, and I was proud to be a co-sponsor of the original House legislation. S. 1440 as amended calls for further studies on factors related to prematurity, improved data on the national burden of preterm birth, continued preterm birth prevention efforts, and strengthened public and health provider education on risk factors for preterm delivery and treatments and outcomes for preterm infants. The legislation also codifies an advisory committee to the Secretary of Health and Human Services on infant mortality and directs the Secretary to coordinate existing quality studies on hospital readmissions and preterm infants. Since the enactment of the PREME Act, we've seen the preterm birth rate decline to its present level of just under 12%, the lowest rate we've ever seen since the late 90s. The good news is there's been progress in better understanding the causes of premature births and promoting interventions that work. On the other hand, however, we still don't know the causes of premature birth in up to 40% of cases. And then there's the cost of the healthcare system of premature births, more than $26 billion each year, not to mention the increased risk of serious disability and death for newborns and the tremendous toll prematurity takes on their families. And that's precisely why the goals of the PREME Act remain just as salient as they were 6 years ago. The second title is similar to the House-passed National Pediatric Research Network Act of 2012 and allows the National Institutes of Health to establish a national pediatric research network comprised of up to 8 pediatric research consortia, or groups of collaborating institutions. The consortia will conduct basic clinical, behavioral, and translational research on pediatric diseases and conditions. Among the 8 consortia, the NIH director will ensure that an appropriate number of awards go to consortia that focus primarily on pediatric rare diseases such as spinal muscular atrophy or birth defects such as Down syndrome. There are many rare pediatric diseases, and in some of these diseases the children are incredibly fragile. If we can allow for research to occur across the country, not just one single location, research can be done at a larger level because children could then participate without having to travel. Additionally, we all know too well that traditionally pediatric research has been underfunded. That can make it hard to train and develop the research talent needed to address these devastating illnesses. The consortia can therefore be the training grounds for future researchers helping to fill the pediatric pipeline. And finally, the third title, Madam Speaker, of the amendment to S. 1440 reauthorizes the the Children's Hospitals Graduate Medical Education, or CHGME, program through fiscal year 2017. The legislation maintains the current authorization level and will support the work of 56 children's hospitals, training over 5,000 pediatric residents in 30 states. The CHGME program was first established in 1999, following declines in pediatric training programs that threatened the stability of the pediatric workforce. Like any parent knows, it's important to have a trusted health provider to turn to when your child is sick or is hurt. And Congress, on a bipartisan basis, recognized that if we didn't create and fund programs to train pediatricians, there wouldn't be anyone left to care for our kids. Since its inception, the CHGME program has been a success story, supporting children's hospitals in their work to train future generations of our pediatric workforce, including pediatric subspecialists in very short supply. Representing only 1% of all hospitals, the small number of children's hospitals that participate in the program train approximately 40% of all pediatricians and nearly half of all pediatric specialists. And that's why continuing this critical program will have a major impact on access to primary care and specialty care for kids. Reauthorizing this program, Madam Speaker, was one of my top health priorities of the year, and I want to thank Chairman Joe Pitts, the chairman of our Health Subcommittee, for working with me on this bill. Together with his help and leadership, we were able to move this bill through our committee and to the House floor last year, and I'm hopeful that reauthorization of CHGME program will finally make it to the President's desk as part of S. 1440. I just want to take a moment to commend Chairman Upton, Chairman Pitts, and Ranking Member Waxman for their leadership on this legislation. I have to recognize and thank the House sponsor of the PREMIE Act and the National Pediatric Research Network Act, and those are Energy and Commerce members Congressman Eshoo, Congressman Lance, Congresswoman Capps, and Congresswoman McMorris-Rogers. They were really dedicated to these important issues. Madam Speaker, I reserve the balance of my time.
Gentleman reserves the balance of his time. Gentleman from Pennsylvania.
Madam Speaker, I yield 2 minutes to the gentleman from Georgia, one of the leaders on this issue, Dr. Phil Gingrey.
Gentleman from Georgia is recognized for 2 minutes.
Madam Speaker, thank you, and I thank the chairman for yielding. The gentleman from New Jersey just gave the attributions to so many members, both Republicans and Democrats from the Energy and Commerce Committee that worked so long and hard on this legislation back originally in 2006 and now in the reauthorization of S. 1440, the PREMIE Act. A lot of statistics that some people may not be aware of. One is the fact that about 2/3 of all infant deaths in the first year of life are among the preterm infants. And in 2008, 12.3% of all live births, over 500,000 babies, were born preterm. Madam Speaker, let me put it a little bit in context. Prematurity or preterm birth is by definition a birth earlier than 37 weeks. Those children are usually not the problem. They're not the ones that end up with permanent disabilities, but there's a subset of prematurity, maybe sometimes referred to as immaturity, children that are born as early as 20 weeks all the way up to 37 weeks. And those children are the ones that very often, if they survive, are left with permanent long-term disabilities. We see a lot of folks on the Hill that coming down the halls of our office buildings, and sometimes they're in wheelchairs, sometimes they're visually impaired, sometimes they're hearing impaired, but so many of those adults and children that we see on Capitol Hill were born prematurely. So a piece of legislation like this is hugely important. I'll end my remarks by just making it a little personal. My wife Billy and I, Madam Speaker, have 13 grandchildren, and the oldest will be 15 years old in about 3 weeks. And they were born at 26 weeks. They each weighed 1 pound 12 ounces, and thank God they are virtually unimpaired today and in the 8th grade and doing well. But you know, it tugs at your heartstrings. This is something that's hugely important. The graduate medical education piece, if I could have another 30 seconds, Mr. Chairman.
You'll know 30 seconds.
And I thank the chairman. The graduate medical education piece is very important because these children's hospitals, they see so many of these young kids. In fact, 50% or more of their patient population are Medicaid, and they need this funding for continuing medical education for residents, pediatric residents. So I'll just conclude with that and just say how proud I am to be supportive of such a great piece of legislation, and I yield back, Madam Speaker.
Back the gentleman from New Jersey.
Thank you, Madam Speaker. I'd like to yield now to the sponsor of the House PREMIE Act, a gentlewoman from California, Ms. Eshoo, such time as she may consume.
Gentlewoman from California is recognized.
I thank the gentleman. Madam Speaker, I'm very proud to rise in support of the PREMIE Act legislation that I introduced with Congressman Leonard Lance. He's been a terrific partner not only on this legislation but on other pieces of legislation that we've moved through the Energy and Commerce Committee, and I salute him. This bill will expand research, education, and prevention of preterm birth. As the mother of 2 children, I know how precious the earliest part of life is. And it's our responsibility to do everything we can to make sure that our little ones begin their lives with more than a fighting chance. Each year, as was stated, each year 500,000 babies are born prematurely in our country. And preterm birth is the leading cause of newborn mortality and the second leading cause of infant mortality. Babies born even a few weeks too early can require weeks to months of hospitalization after birth, and premature birth can sometimes lead to developmental delays and disability later in life. In addition to the emotional and physical toll of prematurity, there are significant health care costs to families, to our medical systems, and our economy. A 2006 report, I don't think the House is in order, Madam Speaker.
Gentlewoman is correct. The House will be in order. Will all members please take conversations off the floor? Gentlewoman may proceed.
Thank you. A 2006 report by the Institute of Medicine found the cost associated with preterm birth in the United States was $26.2 billion annually, or $51,600 per infant born preterm. These are staggering amounts of dollars. And while employers, private insurers, and individuals bear about half of the costs of health care for these infants, 40% is paid for by Medicaid. So it's in the best interests of healthy babies, hopeful families, and the budget of our country to decrease preterm births. The good news is our investment in preventing prematurity is paying off. In 2006, I introduced and Congress passed the first ever comprehensive Preemie Act, and prematurity rates have declined since then. So this is very good news. The even better news is that today we're reauthorizing this law, which holds important programs which will build upon the momentum of the original law and provide us with new tools and knowledge to improve the lives and health of America's mothers and children. The Preemie Act has been packaged with other important pediatric health bills. I thank the chairman of the subcommittee, Mr. Pitts, the chairman of our full committee, Mr. Upton, the ranking member of the full committee, as well as Mr. Pallone, and all of our colleagues. You know very well, Madam Speaker, that we come to this place to do good things for our country, to strengthen our nation. How proud I am that we are living up to that in presenting this bill here today. In closing, I would also like to thank Aaron Kazelneck-Wise of my staff, who has worked on this bill as if it were the most important thing she could do in her life, understanding that it is one of the most important things she could do in her life for children in our country. To the American Academy of Pediatricians, who have been so magnificent in instructing all of us in our work on this legislation, and a particular shout-out to Dr. Phil Pizzo, the Dean of the Stanford School of Medicine, a pediatrician himself, who at one time came from the, worked at, with great distinction, at the National Institutes of Health. So with that, I will yield back the balance of my time. Thank you.
Gentlewoman yields back. Gentleman from Pennsylvania.
Madam Speaker, I yield 2.5 minutes. Gentleman from Michigan, the chairman of the full committee, Mr. Upton.
Gentleman from Michigan is recognized for 2.5 minutes.
Well, thank you, Madam Speaker, and I, too, want to commend the Republicans and Democrats who worked very, very hard to get this legislation to the floor and hopefully to the President's desk as soon as we can, particularly Chairman Pitts and Ranking Member Pallone, Leonard Lance, Anna Eshoo has been Lois Capps, and the staff, really, on both sides. I made a commitment to all these members early on that we would work very diligently to get this legislation here, and we are finally here. Madam Speaker, this bill, S-1440, known as the Preemie Reauthorization Act, is designed to strengthen health care for kids, particularly vulnerable kids. Not only does the bill reauthorize the PREMIE Act, it also includes the reauthorization of the Children's Hospital Graduate Medical Education Program, and it authorized the National Pediatric Research Network. You know, the original PREMIE Act that I sponsored brought attention to the problems related to preterm birth. And since its passage, the preterm birth rate has declined. Good news. But despite that improvement, according to the CDC, still 500,000 babies are born prematurely every year in this country. That's 1 out of 8. We can and we must do better. This reauthorization will continue and strengthen the ongoing effort to track, prevent, and treat prematurity, ensuring that every child has a healthy start and a better chance at a healthy and productive future. Madam Speaker, the National Pediatric Research Network brings us a step closer to providing more help to the kids with unmet health needs, particularly those with rare pediatric and genetic diseases. I've met a number of times with a family in my district, the Kennedys, whose wonderful little daughters, Brielle and Brooke, who are affectionately known in our office as Sleeping Beauty and Cinderella, they have a rare disease called spinal muscular atrophy. And it's often difficult to conduct research into these diseases due to the very small number of kids with that disease. But today, we're working to provide families like the Kennedys and so many others with greater hope for a cure or advancement in the treatment. This bill will help establish pediatric research networks and the consortia that are effective in overcoming gaps in research. Networks and consortia will be comprised of leading institutions that act as partners to consolidate and coordinate those research efforts. With the passage of the Children's Hospital Graduate Medical Education in 1999, freestanding children's hospitals began receiving funds. 30 additional seconds? Freestanding children's hospitals began receiving funds to support their pediatric medical residency programs. And as a result, the number of pediatricians in the U.S. has grown steadily. Today, over 40% of the pediatricians and pediatric specialists are trained in the 57 freestanding children's hospitals that receive this funding. Proven track record, we need to get it done. And again, I congratulate the members on the floor today for getting this bill hopefully to the President's desk before the year is out. Yield back the balance.
The gentleman's time has expired. Gentleman from New Jersey.
Thank you, Madam Speaker. I'd like to yield now to the gentlewoman from California, who's the Democratic sponsor of the House National Pediatric Research Network Act of 2012, which is the second title of the legislation before us. Ms. Capps.
For how much time does the gentleman yield?
Such time as she may consume.
Gentlewoman's recognized.
Thank you. Thank you, Madam Speaker. And I do want to also acknowledge you being in the chair as my partner in the Emerson Capps lectures and my neighbor and a real friend. Madam Speaker, I rise in strong support of the PREMIE Reauthorization Act. This is an important bill to improve the health outcomes of pregnant women and their babies, and it shows our nation's commitment to address the costly and emotionally troubling incident of preterm birth. And while this is enough reason for me to support this legislation, I'd like to highlight 2 additional sections of the bill that will improve the health and well-being not only of newborns, but of our children as they grow. First, it includes the reauthorization of the Children's Hospital Graduate Medical Education Program. This is a critical investment in both the health of our kids and in the health of our economy by bringing new, talented individuals into the healthcare workforce. My years as a school nurse, I know the difficulty that children, especially those with special needs, healthcare needs, experience when they look for a pediatric specialist. And over the years, we have seen how CHGME programs have made a measurable impact in alleviating that burden, allowing these children and their families to focus on healing. I'm proud to be an original co-sponsor of this legislation and will continue to champion it in the House. And while we must ensure that the providers are available for our kids, we are still far behind on too many important diagnostics, cures, and treatments for many of our ailing children. And that is why this bill also includes the National Pediatric Research Network Act, a bill that I co-authored with my colleague, Representative Kathy McMorris Rogers. This legislation will help strengthen and coordinate our nation's research on pediatric diseases. It will disseminate research findings quickly so that all children may benefit, especially those who have rare diseases. And it will expand the geographic scope of research, giving sick kids easier access to research programs and clinical trials. Moreover, this bill places an added emphasis on researching children's rare diseases like spinal muscular atrophy, as my colleague Mr. Upton has noted, and to develop new treatments to fight them. The low prevalence of these diseases makes them particularly hard to research, and yet these diseases have such a marked impact on the lives of far too many of families and communities, like the Strong family of Santa Barbara. My constituents, Bill and Victoria Strong, have worked tirelessly on behalf of their daughter, Gwendolyn, and all children with spinal muscular atrophy and other rare diseases. The work they've done to help raise the profile of pediatric rare disease research is going to help families all across the nation. I thank them, and I thank you. I also wanted to thank the leadership of the Energy and Commerce Committee, Chairman Upton, Ranking Member Waxman, Chairman Pitts, Ranking Member Pallone for their dedication to this bill, and to the staff, especially to Ruth Katz, for working across the aisle and across that Capitol to bring a strong bill now to the floor. I urge my colleagues to support this bipartisan bill. I urge swift passage in the Senate so that we can improve the health and well-being of all infants and all children. And I yield back.
Gentlewoman yields back. Gentleman from Pennsylvania.
Madam Speaker, I yield 2 minutes to the gentleman from New Jersey, Mr. Lance, leader on this issue.
Gentleman from New Jersey is recognized for 2 minutes.
Thank you, Madam Speaker, and it's wonderful to see you in the chair, and I congratulate you on your magnificent service to the people of Missouri and the nation. I rise in strong support of S. 1440 to reauthorize the 2006 PREMIE Act and provide important continued research, education, and intervention in the national effort to reduce preterm births. Madam Speaker, our nation's premature birth rate is one of the highest in the world and is the leading cause of newborn death in the United States. Infants born just a few weeks too soon can face serious health challenges and are at risk for lifelong health and learning disabilities. In addition to its human toll, premature birth costs our economy billions of dollars per year. And while the medical community has made great strides in identifying the risk factors associated with premature births, far too many premature births today have no known cause. That is why the members of the House and Senate have worked in a bipartisan and bicameral fashion to reauthorize the 2006 PREMIE Act so that we may continue to spur innovative solutions that will ultimately lead not just to healthier babies, but lower annual health care costs. I thank Chairman Upton and Chairman Pitts and Ranking Member Waxman and Ranking Member Pallone for their steadfast leadership on this issue, as well as Senators Lamar Alexander and Michael Bennet. Once again, I commend Congresswoman Anna Eshoo of California for working on an important issue to the health and well-being of the American people. While many complain about the partisan nature of Congress, we have worked in a cooperative fashion on this and other issues, as has the entire Energy and Commerce Committee. And it is in that bipartisan spirit that I ask all of my colleagues to join with us in support of the PREMIE Act reauthorization bill so that we as a nation will be able to continue our focus on premature birth research and prevention. And I yield back the balance of my time.
Gentleman yields back. Gentleman from New Jersey.
I have no additional speakers, Madam Speaker. So if you don't, then I would simply ask that we support this legislation and pass it on a bipartisan basis, and I yield back the balance of my time.
Gentleman yields back. Gentleman from Pennsylvania.
Madam Speaker, I have no further speakers. I urge support for this bipartisan legislation and yield back the balance of my time.
Gentleman yields back. Question is, will the House suspend the rules and pass Senate 1440 as amended? Those in favor say aye. Those opposed, no. In the opinion of the Chair, 2/3 of being in the affirmative, the rules are suspended. The bill is passed. And without objection, the motion to reconsider is laid on the table. And without objection, the title is amended. Purpose does the gentleman from Texas rise?
Madam Speaker, I move to suspend the rules and pass Bill H.R. 1845 as amended.
Clerk will report the title of the bill.
H.R. 1845, a bill to provide for a study on issues relating to access to intravenous immune globulin, IVIG, for Medicare beneficiaries in all care settings, and a demonstration project to examine the benefits of providing coverage and payment for items and services necessary to administer IVIG in the home.
Pursuant to the rule, the gentleman from Texas, Mr. Brady, and the gentleman from Wisconsin, Mr. Kind, each will control 20 minutes. The Chair recognizes the gentleman from Texas.
Well, Madam Speaker, I ask unanimous consent that all members have 5 legislative days in which to revise and extend their remarks and to include extraneous material on the subject of the bill under consideration.
Without objection.
Madam Speaker, I yield myself such time as I may consume.
Gentleman is recognized.
And I, too, want to add my thanks and appreciation to my classmate on her years of dedication and just stellar service to the United States of America on behalf of your wonderful state. Thank you. Some of you may remember David, the little boy in the bubble. He was a constituent from Shenandoah, Texas, who passed away at the age of 12 after living many years of his life in a sterile environment at the Texas Children's Hospital in Houston, Texas. His mom, Carol Ann DeMeritt, is a champion for David and for other patients who were born with an immunodeficiency disease. Carol Ann is a friend and a constituent and has worked so hard to help those patients impacted with that disease. For years now, Carol Ann and I and many others have been fighting to change a law that could help patients like David. Intravenous immune globulin, or IVIG therapy, is a vital step for treating patients with certain life-threatening diseases. These are patients for whom virtually every trip outside is potentially deadly. For the 250,000 Americans with primary immune deficiency disease, there's no place more dangerous than going to a hospital for treatment. This is why home IVIG treatment actually prevents people being exposed to common illnesses that may make you and I miserable for a day or two, but could be deadly for patients with suppressed immune systems. Regular access to IVIG therapy means a better quality of life, less disability, and potentially the difference between life and death. Unfortunately, today, current law excludes from Medicare coverage the items and the services necessary to administer this IVIG therapy in the home, where doctors tell us patients with compromised immune systems can benefit the most. The Medicare IVIG Access Act today requires the Centers for Medicare and Medicaid Services to do a couple things. Establishes a 3-year demonstration project to cover these items and services necessary to do this therapy in the home, evaluates the impact of the demonstration project on access for these Medicare beneficiaries, analyzes the appropriateness of implementing a new methodology for IVIG payment in all care settings under Medicare Part B, and updates a previous report on this by the Assistant Secretary for Planning and Evaluation. It's my intent that the required study consider the impact of lag times with respect to data used to determine the average sales price and recommendations to reduce the lag time to ensure more accurate pricing for IVIG, and to report whether home infusion saves the Medicare program tax dollars by improving access to all care settings. The Medicare Payment Advisory Committee recently looked at home infusion, including the access problem for Medicare beneficiaries with PIDD. And the June MedPAC report reported that a target expansion of home infusion coverage focusing on certain drugs would have more likelihood of savings. Drugs with the narrow indication, precise diagnostic criteria like IVIG for PID are less likely to have a woodwork effect than drugs with broad uses or imprecise diagnostic criteria. MedPAC's report also highlighted that fixing the Part B home infusion therapy or benefit for beneficiaries may save money because some of the other covered therapies for these patients are more expensive. I expect, Madam Speaker, the study required by this bill will give us more information about potential savings for from giving people access to the right kind of care, reducing their exposure to germs and other settings, and increase compliance with the prescribed therapy. There may be a lot of division and partisanship in Washington right now, but not about this bill. I'd like to thank my esteemed colleague, Representative Doris Matsui of California, for her leadership and just tremendous hard work on this important bill. We have here today a solid bipartisan bill, and both the House and Senate joined together in support of Medicare IVIG access. And at this point, I would reserve the balance of my time.
Gentleman reserves the balance of his time. Gentleman from Wisconsin.
Thank you, Madam Speaker. I yield myself such time as I may consume.
Gentleman's recognized.
Madam Speaker, I rise in strong support of H.R. 1845. It's a combination of two strong bipartisan common sense bills before the House today. I want to thank my gentleman on the Ways and Means Committee for his support of this important legislation. And as one of the co-authors of the SMART Act, one of the bills that have been combined today with Representative Tim Murphy, and an original co-sponsor of the Medicare IVIG Access Act, I'm glad these two bipartisan bills have been combined and brought to the floor for consideration and hopefully passage later today. The SMART Act had 139 bipartisan co-sponsors. The Medicare IVIG Access Act, with 65 bipartisan co-sponsors, are perfect examples of, at times, Democrats and Republicans joining forces and getting something done around this place. And hopefully that spirit will continue in the days to come with the difficult decisions that face this body. I'd like to thank my good friend Tim Murphy for his leadership and hard work in moving the SMART Act through the Energy and Commerce Committee. I'd also like to recognize the extraordinary broad stakeholder coalition that has worked so hard to help get the SMART Act on the floor today, particularly the American Association for Justice and the MARC Coalition. Finally, I want to thank Representative Brady and Doris Matsui for their tireless efforts on behalf of the Medicare IVIG Access Act. Their legislation is a step toward ensuring all seniors with primary immunodeficiency diseases are able to access life-saving IVIG drugs in their own home. But let me just take a few moments to discuss the need for the SMART Act. The SMART Act reforms the badly broken Medicare secondary payment system. For background, the Medicare secondary payment system requires Medicare to recoup the cost of hospital and doctor bills for a senior if her injuries are the responsibility of a private insurer or some other third party. So far, so good. Making sure Medicare doesn't pay for injuries caused by another third party is good policy to help keep Medicare solvent. The problem is that under the current system, seniors and parties that want to settle a claim often cannot determine how much they owe Medicare. That often results in the settlements to collapse. The result is that seniors are denied settlements to compensate for their injuries. The Medicare Trust Fund is never reimbursed. That's bad for seniors. It's bad for the Medicare program. We're talking about cases where seniors are trying to give money back to the government, and the government simply won't say how much they owe it. It's outrageous that seniors can't even give money back to Medicare that the government is owed because the system is broken down. At a time when Congress is considering cuts to the Medicare benefits and provider payments, we need to at least make sure Medicare is getting the money seniors want to send it. The SMART Act will improve the Medicare secondary payment system by making the government work more efficiently, reducing unnecessary burdens and waste, speeding the repayment of amounts owed to the Medicare Trust Fund. Now, the best way to demonstrate the need for the legislation is with a few examples of the current system's unfairness and outright absurdity. I have a handful of demand letters here sent by CMS to seniors asking to be repaid $1.59, or $2.81, or $4.82, or even $36.75. Those amounts CMS has sought to recoup from seniors far less than the amount it actually costs CMS to pursue these claims. That's penny wise and a pound foolish. The SMART Act makes sure CMS is only pursuing Medicare secondary payment claims that will recoup at least the cost that it takes CMS to pursue these claims. That's common sense reform. This bill makes financial sense for Medicare, but it will also make a meaningful difference for seniors who are awaiting settlements that are held up by the Medicare's process today. In fact, I heard the story of one gentleman who fell on a retailer's handicap ramp while using a walker. Now, Mr. Law cut his left hand. He hit his head on the fence alongside the ramp. He and the retailer discussed the medical charges, and they agreed to settle for $2,000. It took 18 months and 8 written exchanges with CMS to resolve this simple MSP claim, which delayed settlement claim by the same 18 months. Plus, Mr. Law actually passed away during the extended time frame. We can do better for seniors. We can get Medicare the money it's owed a lot faster. This legislation would accomplish that. These are just a few of the examples of why the SMART Act is needed. The toll this broken system takes on seniors and the burden it imposes on businesses is unacceptable. I urge my colleagues to vote for H.R. 1845 to support this common sense reform, including the IVIG program. And Madam Speaker, since this may be the last time I'll have a chance to address you and the Chair, I too want to echo the sentiments of so many of our colleagues to congratulate you on such a distinguished career here in the House. You did well in representing your constituents back home in Missouri. We'll miss you as a colleague, someone who tried hard to work in finding bipartisan common sense solutions to the challenges facing our nation. And of course, we wish you all the best in your future endeavors. I'll reserve the balance of my time.
Gentleman reserves the balance of his time. Gentleman from Texas.
Madam Speaker, I would ask unanimous consent to include in the record exchange of letters between the Ways and Means Committee and Energy and Commerce related to this bill.
Without objection.
This time I would yield 2 minutes to the chairman of the Health Subcommittee, a longtime fighter for patients and those on Medicare, the gentleman from California, Mr. Herger.
Gentleman from California is recognized for 2 minutes.
I thank my friend from Texas. Madam Speaker, I rise today in strong support of H.R. 1845 as amended. The Medicare IVIG Access and Strengthening Medicare and Repaying Taxpayers Act of 2012. This legislation would create a 3-year demonstration project to provide up to 4,000 Medicare beneficiaries suffering from primary immunodeficiency diseases with in-home coverage of IVIG. Medicare beneficiaries with PID need the biologic IVIG to boost their immune system so they can fight off infection and maintain a high quality of life. Medicare currently offers comprehensive coverage of IVIG treatments in the physician office and hospital setting, but not when IVIG is administered in the home. This flawed payment policy encourages Medicare beneficiaries to receive care in the most costly settings. Under this demonstration project, Medicare Part B would cover the home administration costs, including the trained medical professional who administers the biologic, allowing up to 4,000 beneficiaries with PID to receive IVIG treatments in their home. Importantly, beneficiaries who receive IVIG in their home can avoid the risk of infection inherent in alternative treatment settings. The HHS Secretary would be required to issue a report to Congress detailing the impact this demonstration project had on beneficiary access to care and whether or not CMS should permanently change its IVIG coverage policy. According to CBO, the costs of this one-time demonstration are fully offset by permanently reforming Medicare's secondary payer rules as detailed in the SMART Act. The SMART Act will help ensure that taxpayers will not be stuck with a Medicare bill for incidents caused when another party is liable or negligent. The SMART Act also makes important changes so that the arcane Medicare rules would no longer be an impediment to parties resolving their indifferences and reaching settlement.
I'd like to extend another minute from California.
Madam Speaker, we need to protect the Medicare trust funds, and we need to have an efficient, consistent, and clear process to resolve these claims. And the SMART Act does exactly that. I urge my colleagues to join me in support of this important legislation. I yield back the remainder of my time.
Gentleman yields back. Gentleman from Wisconsin.
Thank you, Madam Speaker. And Madam Speaker, I want to thank my good friend and the gentleman from California for his support of 1845, in particular the SMART Act, and congratulate him as well on his distinguished career, since he will be retiring at the end of this session of Congress as well. But at this time, I'd like to recognize the gentlelady from California and the principal author of the Medicare IVIG Act, Ms. Matsui, such time as she may consume.
Gentlewoman from California is recognized.
I'd like to thank my colleague for yielding, and I also want to say, Madam Speaker, thank you for your many wonderful years of service and our friendship. We'll miss you in this chamber, and we wish you well.
Thank you.
Madam Speaker, I rise in strong support of H.R. 1845, the Medicare IVIG Access Act. I'd like to thank Congressman Brady for his hard work and his leadership in this legislation, as well as Congressman Kind for the leadership on the SMART Act provisions of this important legislation. Primary immune deficiency diseases, or as we call it, PIDD, is a group of diseases that cause a person's immune system to be unable to function properly. Unlike most of us who are able to fight common infectious diseases, patients with untreated PIDD can become seriously ill from a simple cold virus or even a cut on their arm. Patients with PIDD are generally treated with intravenous immunoglobulin, or IVIG, a complex drug that provides them a temporary immune system. Every 3 to 4 weeks, patients receive an IV treatment for about 2 to 4 weeks per treatment, 2 to 4 hours rather per treatment. To maintain a healthy immune system, they must have this treatment for the rest of their lives. People with commercial insurance typically receive care in any of 3 settings: hospital outpatient department, a physician's office, or at home, administrated by a nurse. For many patients, receiving their care at home is optimal, as it greatly reduces the risk of infection. However, the Medicare beneficiaries with PIDD, the program pays for home infusion of IVIG, but does not cover the nursing services and supplies. As you can imagine, a 74-year-old Medicare recipient on a fixed income is not capable of paying the several $100s a month necessary for the nurse to provide IVIG infusions in their homes. As a result, many patients are forced to receive their treatment in a hospital setting, oftentimes increasing the likelihood of infection, pneumonia, and expensive stay in a hospital billed to Medicare. Madam Speaker, this does not make sense for the patient or for Medicare. And that's why Congressman Brady and I introduced the Medicare IVIG Access Act. Madam Speaker, this legislation is budget neutral and fully paid for. H.R. 1845 creates a 3-year demonstration project capped at 4,000 patients, in which the nursing services and supplies associated with home infusion of IVIG will be covered for Medicare beneficiaries with PIDD. I believe that this project will mirror the results of studies of patients with commercial insurance that found increased compliance, fewer infections, and overall savings for patients infused at home versus the hospital. Madam Speaker, patients with rare genetic diseases should not see their access to care diminish when they become eligible for Medicare. H.R. 1845 fixes the gap in Medicare coverage that unfairly restricts patients' access to IVIG and disrupts their continuity of care. I strongly encourage my colleagues to vote for this critically important legislation, and I yield back the balance of my time.
It's for time. Gentleman from Texas.
Madam Speaker, I'm pleased to yield 5 minutes to the lead author, champion of the SMART Act, and one of our health care leaders, Mr. Murphy, Pennsylvania.
Gentleman from Pennsylvania is recognized for 5 minutes.
I thank the gentleman, and Madam Speaker, may I add my accolades to your work for the people of Missouri, particularly my ancestors who founded Murphy's Settlement, now Farmington, your district. You've done them well. 4 years ago, Lorraine Babbage of Washington County, Pennsylvania, then age 73, suffered injuries so severe from a car accident that she will never fully recover. After the accident, Lorraine underwent a very difficult surgery. She was transferred to a rehabilitation facility where she contracted methicillin-resistant Staphylococcus aureus, otherwise known as MRSA. Sadly, Lorraine's condition has worsened, and she now suffers from dementia and must receive 24/7 care at a nursing home. The physical pain in Lorraine's life is multiplied by the emotional pain of recent years. A year after the accident, Lorraine lost her husband. Then last year, her only child passed away. Lorraine's story is heartbreaking and tragic, and it's depressing to learn Medicare is working against Lorraine's interests. In the fall of 2010, Lorraine's family and the automobile insurer for the other driver in the accident reached a monetary settlement. The insurer agreed to pay Lorraine's medical bills, and Lorraine would also collect damages. First, Lorraine's health insurer, Medicare, had to be repaid. But the Centers for Medicare and Medicaid Services won't tell Lorraine or the auto insurer how much is owed to the Medicare Trust Fund. The insurance company wants to reimburse Medicare and provide Lorraine with a settlement, but CMS's complicated bureaucracy is standing in the way. Now, there are thousands of cases just like Lorraine in the congressional districts across the country, but we now have a chance to fix this problem and make sure Lorraine and her family receive what they are rightfully owed by passing H.R. 1845, which includes a bipartisan bill I introduced with my friend Congressman Ron Kind. Our bill, the Strengthening Medicare and Repaying Taxpayers Act, or the SMART Act, will recoup billions of dollars owed by insurance companies to the Medicare Trust Fund quickly and eliminate waste within CMS. The SMART Act, which has nearly 140 bipartisan co-sponsors and the support of trial lawyers, patient advocates, defense attorneys, and the U.S. Chamber of Commerce, requires that Medicare provide settling parties with accurate information about the total costs of medical bills when the parties announce a settlement is near. The Congressional Budget Office has looked at our bill and found it will save millions in overhead costs at Medicare. The current Medicare secondary payer bureaucracy is causing seniors to have their Social Security checks garnished and their Medicare coverage denied through no fault of their own. Our bill fixes these issues, and it ensures bureaucracy does not stand in the way of a settlement. Right now, insurers are walking away from settlements because of the flaws of the Medicare secondary payer statute. And when those settlements break down, seniors get nothing, and the taxpayers are not repaid. By enacting this legislation, Congress can help Lorraine and thousands of senior citizens who are needlessly suffering because Medicare isn't operating effectively and efficiently. I want to thank Chairman Upton and Camp, Ranking Members Waxman and Levin, and Congressman Kind for their support in this legislation. I want to extend a special thanks to their respective staffs for their hard work, particularly Robert Horn and to Brad Grants. Without them, this legislation wouldn't be moving forward. This is good government. This saves taxpayers money. I urge its adoption, and I yield back.
Gentleman yields back. Gentleman from from Wisconsin. The chair needs new contact lenses.
This time I'd like to yield to my very good friend, the gentleman of New Jersey, and one of the leaders of the Energy and Commerce Committee, Mr. Pallone, such time as he may consume.
Gentleman from New Jersey is recognized for such time as he may consume.
Thank you, Madam Speaker, and I want to thank the gentleman from Wisconsin. Madam Speaker, I rise to lend my support to H.R. 1845 as amended. This bill combines two pieces of legislation, H.R. 1845, which provides a demonstration for the coverage of home infusion of intravenous immune globulin, or IVIG, and H.R. 1063, which makes improvements to the Medicare secondary payer process, or MSP. However, I would like to note my concerns about the process. Our committee acted on H.R. 1063, and I commend the chairman for his efforts to ensure it was a bipartisan product. But we did not act on the IVIG legislation, which is every bit as important to our members as the MSP. So it's my hope that in the future we can avoid situations like this. The Medicare secondary payer provisions of this bill will reduce the burdens of the secondary payer process for beneficiaries and other stakeholders. Most importantly, the legislation will do so in a way that ensures that we're also protecting taxpayer dollars and the Medicare Trust Fund. I do worry, however, that the MSP bill does not include administrative funding for the Centers for Medicare and Medicaid Services, or CMS, to implement these new changes. One of the primary complaints I hear about MSP is that stakeholders are currently frustrated because the process does not move fast enough. But here we are legislating new responsibilities for CMS on top of an already slow process with no new funding. This will simply burden the agency and make it more difficult to get to resolution on secondary payer cases in a timely fashion. So I hope that at some future date we can provide a reasonable sum to the agency to allow them to be better equipped to speed this process along. One additional point on MSP. The new process we've established for resolving disputes of claims posted on the web portal is not intended to supplant the ordinary appeals process for MSP activities. I believe that is clear in the language, but I want to note that there should be no ambiguity. This bill does not supplant existing appeals rights. In addition to MSP changes, this bill also provides for a 3-year demonstration related to IVIG. IVIG is a blood-derived treatment that helps strengthen the immune systems of immune-deficient patients and prevents paralysis in some autoimmune diseases and neuropathies. Currently, Medicare beneficiaries may receive home infusion of IVIG as a Part B benefit. However, the equipment, nursing services, and supplies necessary for the home infusion are not reimbursed. Now, Congresswoman Matsui has been a clear leader on this issue, and it's to her credit that it's included in this package today. She's worked so tirelessly on this IVIG issue, and I'm hopeful that this demonstration project she has championed will both save money for the Medicare program and improve access to needed services for this vulnerable population. And I thank her for her leadership on behalf of these patients. I also want to thank Chairman Upton for working on these two issues with us, and I look forward to the next Congress where hopefully we'll find additional areas of common ground to work on. So thank you, Madam Speaker, and I reserve the balance of the
Gentleman reserves the balance of his time. Gentleman from Texas.
Madam Speaker, if there are no other speakers at this time,
I'll support H.R. 1845, and I'll yield back at this time.
Gentleman from Wisconsin yields back.
Well, in closing, I yield myself so much time as I may consume. But in closing, I want to thank my counterpart, Doris Matsui, for great work on this issue, and I so appreciate the leadership and partnership of Mr. Kind and Mr. Murphy in combining these two important health care bills in order to both provide safer, more affordable access to care for those with compromised immune deficiencies, as well as finding ways to save money with the important Medicare program and the SMART Act. I want to thank Dan Elling, Staff Director of the Ways and Means Subcommittee on Health, as well as Jennifer Safarian for her leadership of Ways and Means Committee. But I especially want to thank my constituent friend, Carol Ann DeMeritt, the mom of David, for her decades of hard work on behalf of these patients. And I appreciate so much Marcia Boyle, the founder of the Immunodeficiency Foundation, all those patients who for years have come up here asking for this help and change. Today, this Congress, Republicans and Democrats alike, join together in providing that help and that access. I urge support for this bill and yield back.
Gentleman yields back. The question is, will the House suspend the rules and pass the bill H.R. 1845 as amended? Those in favor say aye. Aye. Those opposed, no. In the opinion of the Chair, 2/3 being in the affirmative, the rules are suspended. From Texas. The yeas and nays are requested. All those in favor of taking the vote by the yeas and nays will rise and remain standing until counted. Sufficient number having arisen, the yeas and nays are ordered pursuant to Clause 8 of Rule 20. Further proceedings on this motion will be postponed.
Great schedule, we got 3 votes now. You're in very questionable company out there. Are we about to have a vote?
We're about to have a vote. Our lucky day.
So just tell Andrew to just stay over there.
Okay.
Have you had your speech already? Good speaker who's on break.
Pursuant to Clause 8 of Rule 20, proceedings will resume on motions to suspend the rules previously postponed. Votes will be taken in the following order. H.R. 6672 by the yeas and nays. H.R. 1845 by the yeas and nays. House Resolution 668 de novo. First electronic vote will be conducted as a 15-minute vote. Remaining electronic votes will be conducted as 5-minute votes. The unfinished business is the vote on the motion of the gentleman from Michigan, Mr. Rogers, to suspend the rules and pass H.R. 6672, on which the yeas and nays are ordered. The clerk will report the title of the bill.
72, a bill to reauthorize certain programs under the Public Health Service Act and the Federal Food, Drug, and Cosmetic Act